kids out there, teenagers, adults, elderly, everybody can begin to recognize eating disorders in all groups, all colors, all shapes, all sizes, all ages. That's
one of the paradigms I like to use in my mind about whose responsibility it is to think about the intention to recover versus the healing process. And I had to sort of work this out in my own mind in treating treatment refractory patients. Like, am I doing good for the patient if I'm sort of like feeling like I'm the one that wants this more than the person who's in treatment with me, and coming, because I think back in the substance abuse treatment days, I used to say, well, I think the answer we gave ourselves as clinicians to get us off the hook was that line that she's not ready, that line of he's not ready, and then that kind of took everything off the table, and you didn't have to, you know. So I came to terms with realizing that there is a purpose to the healing process of just that shared experience in therapy, where you may not say, okay, my goal is going to be that I'm going to get this person gained 2 pounds this week. You know, that may not be the outcome, but that it's okay to have that relationship and to be building that trust, even if the person themselves isn't really able to say at that particular moment in time, I intend to recover. That there's still a function to the development of the relationship.
And I just wanted to comment on something that a couple people said about the team all communicating with one another. Like Jenny said, on the ball field, if the pitcher's throwing the ball and the other people aren't paying attention or aren't clued in to what the purpose is or what the plan, you know, what that game play might be, then it's not really going to work very effectively. So I think that's a really important piece that the team is communicating.
Yeah, especially if you're getting outpatient services and you're not, you have to advocate, like whether it's yourself, your family members, or your caregivers, you have to advocate that that team has meetings, that they talk to each other as, you know, often as possible. So it doesn't naturally happen all the time in outpatient settings.
Amy, did we help answer your question? Any more clarification on it? Any other audience questions on that related to that responsibility? All right. Now we're going to talk about the DSM. That's an interesting array of things. So the question is, the DSM criteria, just to quick back up, the DSM criteria are the diagnostic and statistical manual criteria that define what different mental illnesses are. So eating disorders are in there, and there's a current definition of them. It's been changed a couple times over the past 20, 25 years. And they keep getting changed based on research and clinical experience and a number of other things. So they're in the process of being revised right now. It will come out in 2012. So the question was, the DSM criteria are currently under revision, and if you could define your dream criteria, what would it look like? So maybe as you're answering that, you could, I'm imagining you speak to sort of why the current ones don't work, but if there's anything particularly you want to highlight about why they don't work and why that, your dream will address that. So Ted, you're the first dreamer.
Okay. Well, the one thing about the process of DSM is, you know, I think it's very nice that people kind of recognize that diagnostic criteria is not lining up with a lot of things that are important. It doesn't really line up with possible etiologies of eating disorder. It doesn't line up with treatment or treatment efficacy. And it also doesn't line up with kind of the prevalence of eating disorders, right? So, for example, I think the notion that anybody would question binge eating disorder being a DSM diagnostic, you know, a diagnosis is really mind-boggling and very political. That's the only level it can really exist at. So I think that, you know, if you really think that 25% of obese people have binge eating disorder, and you think about 40% of the population being obese, and you think about 300 million people in America, you know, there's more than 3% of the population that has an eating disorder. And, you know, and politically, you know, greatly increasing the numbers of eating disorders creates significant problems for healthcare funding in this country. It's as simple as that. I don't think there's any other logical reason for And you can understand it. I mean, there's always been a move to keep obesity from being a medical illness because of treatment. You know, it's going to be very costly. The unfortunate thing about it is that we have a lot to learn from binge eating disorder and the treatment of binge eating disorder. I mean, and the more people that you can actually treat with eating disorders, you know, it's better for everything. I think the second thing I would say is that issues around age and gender and socioeconomic status need to really be completely out of the diagnostic criteria, and out of treatment trials, and out of treatment. I think that, you know, that there's no other medical illness that I know of that is gender-based in diagnostic criteria or treatment approach. I mean, even breast cancer, you know, is not. Men get breast cancer, and you know, there's no real problem with accepting that. But I think, you know, I think that really holds us back in terms of, you know, what. I mean, the analogy I use is cardiovascular disease and smoking in women. You know, if we think back 30 years in terms of heart disease, all the studies were done in men. And what's transpired over the last 20 years is really all the, you know, the risk factors that we knew were prevalent have greatly increased in women, and cardiovascular disease is now one of the leading cause, if not the leading cause of death in women. So, you know, we don't want to repeat that with eating disorders and gender. I think my understanding of what is possibly going to happen is there's going to be 4 major diagnostic criteria. There's going to be an anorexic criteria without its rigid weight expectations. So, for example, people with bariatric surgery patients who aren't eating, you know, essentially they have anorexia, and why not treat it that way? Bulimia is not going to have the strict criteria in terms of frequency and duration. So if people have, you know, appetite discontrol and compensation, they have that. The binge eating disorder as another one, and then I think picky eating in kids is the 4th, which actually is, you know, actually does also bring in a population that we actually get a lot of calls about in terms of kids and eating problems. And I think the other thing you could actually kind of include, but I don't think they will, is appetite disturbances in the elderly, where you'd also get this other thing. So I think that, you know, you would, you know, to kind of shift this to something that's more intuitive as you think about how you treat people, I think is something that I would really like to see.
Sure.
This is where the confession comes up to start. This is one of my primary areas of interest in research, and the way some people follow American Idol and the Super Bowl. If the DSM-5 committee had Twitter, I'd be signing up. So Ted actually just did such a lovely summary of where we are. I thought I'd start by saying my understanding of sort of the varied at least researcher positions on this. One view out of Oxford was that we should just have one diagnosis, eating disorder, and make it broad, sort of figure out, delineate what's a case versus a non-case, and they had various ways of doing that, but all this business of trying to subdivide it didn't make sense, and they also argue this based on the fact that, in their view, a lot of the underlying issues are the same. So that's one view. Another view by Pamela Keel and others is that we've been too stingy in the DSM and don't have enough diagnoses. And so that's why we have this big problem with eating disorder NOS having so many people in it, and we need to subdivide it more kind of in keeping with who we see clinically. Her great quote is, if we have different labels for alligators and crocodiles, then we should have more labels in the DSM, which I really like. And then the third, and as Ted's describing, I think it's going to be a combination. There's going to be maybe one more category, but this is the main way it's going, is to make the existing categories more flexible. And I think that this is really probably the direction that it's going in. So in trying to think about what my dream criteria were, I actually came up with a top 10 list, and then remembered that I had a 2-minute time limit, and I could never make that, so I came down to 5 instead. And what's interesting is they actually, it's more in content actually, I think, than in what's actually in there. First, that we make the DSM criteria work for its main purpose. Tim Walsh, who headed the DSM-4 committee and heads the DSM-5 committee, does such a beautiful job on this, and he really emphasizes that, you know, as much as it's used for insurance reimbursement or research criteria, as Ted says, this needs to be about clinical utility, and that needs to be the main priority. And I think as researchers, we get all, you know, in a buzz about this, but sometimes we really need to just come up with our own